let's say thank you all for joining the session today. This is a patient empowerment educational series that's being hosted by Cancer Awareness Network, of which I am a co-founder, and Tia Tumlin with My Style Matters. We're both advocates for cancer, and both in our different areas. Tia is actually in Atlanta area. I'm in the Birmingham, Alabama area. So I want to welcome you to May Part 1 series. We will actually do 3 series. This is the first series. And then in June and July, we'll have Part 2 and Part 3 respectively. Cancer Awareness Network and My Style Matters decided to team up to do this project to help cancer patients do some things to would better improve their lifestyle and keep a focus on what's happening in our cancer community in the midst of all of the craziness of the COVID-19 pandemic. We are hosting these series so that we can help our cancer survivors, caregivers, and healthcare providers dealing with the diagnosis of cancer. During the sessions, you will be able to, I see somebody else, I'm gonna let them in, I'm sorry. During the sessions, however, you will be able to ask questions through the chat box at the bottom of your screen. But some of the questions we'll try to save toward the end so that our speaker can have time to do her presentation. And so we want to first of all congratulate Yolanda Bronson, the winner of our registration gifts for cancer survivors. We actually do gifts for these survivors that join these sessions. And so each of your names will be entered into a drawing. At the end of the session, I will come back and we will address any questions that you have and also recognize our sponsors. And so at this point, I would like to introduce to you our speaker for the hour, who is Dr. Sharon Spencer, a professor of radiation oncology at UAB Birmingham, where she also holds a position of Ruby Meredith Outstanding Clinical Clinician and the Radiation Oncology Endowment Chair. Dr. Spencer also serves as the clinical director of UAB Department of Radiation Oncology and the chief of medical services for radiation therapy programs at UAB School of Health Professions. Dr. Spencer earned her medical degree and Master's of Science degree in Health Administration from the University of Alabama at Birmingham. However, she has also completed her internship of residency. She's a board certified radiation oncologist. Dr. Spencer has been a vital voice in the African American community here in Birmingham as an advisor to Cancer Awareness Network for children for the past 20 years. She has been the key speaker for each of these informative workshops, empowering cancer patients and caregivers of all types of cancer. To honor her legacy, this organization has set up awards to recognize her for her scientific work, and it is a time when she is able to highlight those young scientists that she worked with and other community leaders to receive this prestigious award. And so with that, I would like to introduce to you our speaker for today, Dr. Sharon Spencer. Dr. Spencer. All right, you got it on. Okay.
Okay. Thank you so much, Loretta, for that wonderful introduction, and to both great organizations who have stepped out to try to make a difference in the lives of cancer patients and in all patients. So Mrs. Heron asked me to do a talk similar to one that I've given before. Hopefully it's not too simple, but sometimes patients do come in with questions about cancer that they maybe were a little bit afraid or intimidated to ask their provider about. So we will try to see if we can touch upon some of the facts about cancer and see what questions we get at the end. So what do we know in 2020? So what we want to do is to just look at some of the fundamental factors about cancer. Hopefully this will help patients and their families. The American Cancer Society is the organization that really shares a lot of information with not only the United States, but with the world. They're world leader. And basically, the cancer diagnosis is the second leading cause of death in the world. And so as of 2018, 17 million new cases were noted and 9.5 million deaths were noted. And as we get the blessing of aging, we also get sort of a deficit, because as we get older, then a lot of times we have to deal with malignancies later. So as the population gets older, we anticipate there will actually be more cancer cases arising around the world. So what do we know? I mean, so I've been working in oncology for several years, but it gets pretty thorny sometimes, and it's almost like looking for a needle in the haystack. And sometimes we are fortunate enough to come upon some great discoveries and information and pass that on to patients, but sometimes it can be fairly slow coming, it appears. So just to sort of go back to see, well, when was cancer first documented? There was an American Egyptologist who actually did a lot of excavations in Egypt and found the papyrus that documented that physicians or medical folks in Egypt as early as 2500 BC were documenting something that appeared to be tumors or cancers, even though this was a little vague, but this is some of the earliest information that has been found by archaeologists. We all know about Hippocrates. You know, cancer during his lifetime, you know, he was a Greek, and so he was very inquisitive. And the only thing they had at that point were patients who, or individuals who came in with abnormal growths. And so they documented what they saw. And so he was the first person to actually give us some of the terminology that we use sometimes frequently. Carcinogens, or we know about the giant crab. And this is sort of the root word for carcinomas that are attached to the diagnosis that patients get at this time. So there was also a 2nd century Greek physician who coined the terms for malignancies, again, using the word carcinogens. I know sometimes patients will come in and they will have their path report in hand, but the terminology carcinoma and this oma is really sort of one of the root words for abnormal growth. And so oncology itself is a study of tumors. And so those are great distinctions that patients need to know if this is their initial sort of encounter with cancer. Some of the terminology can be really difficult. Is it benign? Is it malignant? Is it a tumor? Sometimes doctors and healthcare providers will use these words interchangeably. And so, but if you see something that says oma, carcinoma, that usually means that the disease is of a malignant variety. So Einstein sort of coined it best. So even now in this century, we know that cancer is not just a single disease. And the origins and the mechanisms that drive their growth and their clearance and their cures are not clearly defined. So basically, we are in this vast ongoing research that never stops. And so it seems like the more we learn, and Einstein said it, the more I learn, the more I realize how much I don't know. And so some of the mechanisms that have been uncovered in the last 10 years or so, we thought they were pretty cut and dry. And then we found out that there is just underneath the surface many, many mechanisms that are interchanging. So this field is incredibly dynamic, just like the cancers themselves, incredibly dynamic. So back to your basic middle school biology, you all studied about the cell. So everything really starts there. It's sort of the blueprint. It's where all the information lies, because within it, there are these chromosomes that kind of dictate everything. And so even just this simple diagram is a huge community and ongoing efforts are made each day to just study things such as the mitochondria. And when we were kids, we learned that that was sort of the powerhouse of the cell. That's where all of the ATP and so forth interactions occurred. But we find out now all of that energy is also important within the study of cancer. So each little segment is unique and very important in the life cycle of a cell, and important for cancer as well. So you can see sort of in the middle of the field, if you remember, sometimes I would get nightmares about this, is sort of the cell division, mitosis and meiosis is what that showed. But as these cells divide, what happens with them? So if you look at this very, very simple diagram or picture, it just shows you that the what we call the basement membrane of cells, which is sort of the orange color cell, which is a normal. When things go awry, then there's an accumulation of cells that actually break through that membrane. So for whatever reason, their cohesive ability, their ability to migrate, their ability to communicate with each other, certain switches are turned on and they can communicate, release enzymes, which break down the normal barriers that we have in place. So once cells start to do this, they can get into the blood vessels, and then they can become metastatic. And that's what the secondary tumor diagram is about. These are secondary tumors that come from the parent tumor, so to speak. So if a tumor is what we call less aggressive, a tumor that's not malignant, it doesn't have the ability to go beneath the cell membrane and get into the blood vessels. So we'll use just an example, because there might be some folks on the call who have had prostate cancers that they were told were in situ, or breast cancers that they were told were in situ. So it's a disorder that has the ability to become malignant if not extricated with surgery or whatever, before the communication signals and signaling between cells sort of tell the cells to become malignant and to invade into the tumor, so into the tissue. So you will hear the terms in situ, meaning that it is not below the basement membrane and thus does not have the ability to get into the vasculature, the lymphatics, and cause metastatic disease. So that's just a simple way to think about it. But so what happens to these cells? So you have normal cells that start out and they go through their normal division, but for whatever reason, there is a abnormal signal that signals a cell to mutate. And then after that cell mutates, it goes through several divisions. And finally, it is very malignant and very aggressive after it has gone through several mutations. So our epidemiologists are very important in the study of oncology because this is a branch of medicine which studies the incidence of cancer, the distribution of cancer, what common things do they see among cases that would predict that patients might do better versus another group of patients. So their information is very important. And that's a very important branch that we don't talk about and you don't hear about, just in the lay community. So these doctors are there gathering stats about all sorts of things, how long people survive, what countries they're in, what ethnic groups they're in, you just name it, lifestyle, physical activity. That group is a very important group because they, along with the statisticians, pull together just volumes and volumes of information about cancer diagnoses and how people behave after they've been diagnosed with cancer. So a lot of you have probably heard of the Human Genome Project. That was a huge undertaking that took about 13 years to actually get it all done. It was done by several countries, so it was not just the US that was involved in that, but there was the work that sequenced all of the human genome. And so that was very important. So now what we have is we have a library of information that scientists can use to, again, do epidemiologic studies. They can also use this library to build hypotheses about what the next generation of research should look like. And so this is a very important project that you will hear folks talking about from time to time. And then the old DNA that we studied again back in high school, biology, and in middle school, it has everything to do with our ability to inherit things and the inheritance patterns that we see. And so if something becomes abnormal with the way the DNA replicates itself or divides or carries out its function, or if there's something wrong with some protein synthesis, which the RNA is responsible for a good bit of that, then our proteins and enzymes are not as they should be. They have some deficits, and so that can sometimes lead to malignancies as well. So this is just a table that I found. We always wonder, okay, where did this cancer come from? Did it come from my bloodline with my parents or my grandparents? How did I get this? And so this is just a short list of some of the inherited diseases that folks can get. And if you get some of the common cancers such as breast or ovarian cancer, then a lot of times they will check you for BRCA problems or some sort of deficit there if you have those genes in play. But we have to understand, just as that says, that the incidence for that abnormality is pretty low. If you look there at that incidence, 1 out of 300 to 800. But if you're of the Jewish population, then it's pretty high, 1 out of 40. So definitely inherited, but as you can see, probably most of our ovarian cancers, most of our breast cancers, most of our prostate cancers are not secondary to this abnormality. And so scientists have known that for quite a while. And so it makes us dig a lot farther, because this is not the explanation for everyone. So if someone has this abnormality, then you can really pass this information on to your the next generation, children, grandchildren. So it's very important to discover if it's present, because the geneticist can help, and the physicians and the whole care team can help patients make decisions about what they want to do if they have inherited this from their mom or from their father. And so a lot of times, you know, so there's not a genetic problem. Okay, so what on earth happened? So there's a whole now a area called epigenetics. And basically, epi just means on top or over the genetics. So you have a basic genetic pattern. So your DNA has certain codes that are written on it to carry out different functions. But how can we influence the genetics? And so this is a whole field of study now, epigenetics. And, you know, we sort of nibble at it a little bit. We go like, well, is it the environment that I grew up in? Is it the nutrition? Is it physical activity? Is it smoking? Is it, you know, alcoholic beverages, stress? We do know that as we age, as I said before, then our risk for cancers just naturally go up. But epigenetics is a wide open field now of medicine that is looking at all of these factors and many more that might have something to do with the development of cancer. So it overrides your genes and the information that's there, and can sometimes lead to illnesses and so forth. One thing that they found out about the genetics, so for some of the chemists who might be in the audience or biologists, there is something that is called methylation of the DNA. And once that happens, it's sort of an obstruction to the structure of the DNA. And so it represses its ability to be transcribed correctly. And so you can get some missense information just from that, that methylation that happens within the DNA. And so we know that there are some common carcinogens. The International Agency for Research, they have a website you can go to and look at some of the things that are there. And of course, there are many more. The ones that we know about are tobacco. We're learning more and more about things like tobacco that you chew. The combustible tobaccos such as smoking, cigarettes or cigars, or we're learning more about vaping. We don't know a lot about that yet. We know that it causes some lung injury. And so secondhand smoke, there have been epidemiologists have looked through families and found out if you live in a house and you get a lot of exposure over time, probably as a youngster, then that could probably put you at risk for some epigenetic changes to your basic genes. Radon gas, asbestos, formaldehyde, out in the sunlight too much, and without sunscreens and proper protection can sometimes lead to some devastating skin cancers. The foods that we eat, of course, and this is one of the biggest questions that we get. I don't care where you're giving the talk. We want to know, what are we eating that might have an epigenetic role in cancers that we develop? Is it the red meat? Is it the nitrites in meat? And again, epidemiologists seem to be able to tell us that in certain countries where there's a lot of nitrites and a lot of salty products, like in certain parts of Asia, that there's a high risk for certain things like gastric cancer and esophageal cancer. So looking at some of those studies, there probably is a connection, and those connections are pretty strong. Heating food to wrong temperatures, and that is sort of a target all over the board. Some folks believe that if you denature the protein structure in meats, that this can be a carcinogen. And we're learning more and more about viruses. It's sort of interesting in that we're in this COVID pandemic, but there are several viruses that are now being studied. One for sure that you've heard about is the human papilloma virus that causes cervix cancer, of course. And then there are now these large studies looking at HPV-associated head and neck cancer. And so in years past, we thought that all head and neck cancers were caused by either chewing tobacco or smoking tobacco. But what we're finding out is that a large number of these cancers are now caused by these HPV viruses. There's something called an Epstein-Barr virus that, again, is common in Asia, but we see a variety of the Epstein-Barr virus in the US that might be responsible for some lymphomas, responsible for some of the head and neck cancers that we see in the nasopharynx. And in terms of the bacteria, there's something called Helicobacter, which has been found in patients who have stomach cancer. And so they believe that that specific bacteria in some folks, again, it's not 100% across the board, but it can also cause stomach cancer in some people. So if you look at lifestyle behaviors, just this year in 2020, there were, if you look through PubMed, and you can do that sometimes, it's a government website, you can look for articles there. So 19 articles published so far on lifestyle. Diets, meats are in some of these publications, antioxidants. And then I think everybody now, it's almost like it's a fad that your doctor wants to know what your BMI is, your body index. And if you go back to the Lancet, which is a very well-respected journal, back as far as 2014, they were documenting that this index was important for not only cancer patients' survival, but just good health all over. So heart disease and vascular disease. And again, this is just a lifestyle things. It's like what we eat or the lack of exercise. A few years ago, there was a huge craze about vitamin D, the vitamin that you get activated in the sunlight, and the one that we have to take as a supplement, especially for females as you get older if you have problems with your bones. And so exercise, again, that's a whole new field of investigation, and we just don't have the answers to all of these things. So the burning question is, what can I eat? Do I just eat the Mediterranean diet? Is that good enough? Do I exercise 3 to 4 times a week? We know that those things are good for good health. Fresh vegetables, fresh meats. It is almost getting back to the agricultural lifestyle that not only Americans had many years ago, but across the world. That was the way that people lived. They grew their own food. And so we know that those diets are healthy. Heart health, very important. And in the breast cancer population, they found out that people who eat a certain type of foods, really leaning more towards the vegetarian type diet and the oily fish diets, such as the salmons that have the omega-3 fatty acids in them, are very healthy. And in comparative studies, again, these are the epidemiologists who are telling us this, that once you're diagnosed with a disorder, you seem to do better if you can adhere to that type of lifestyle. I didn't put here anything about diabetes or the inability to basically break down sugars properly. That also has been associated with certain types of cancers. So again, it's lifestyle, eating. It's almost as your health teacher told you when you were little. We are what we eat, and we have to be active, and we need to move in some way, form, or fashion. And this is a very intense area of research. It's the microbiome. So what we have, these microorganisms that live in our bodies. They're in all sorts of compartments of our bodies. There are certain bacteria in your mouth, in your nostrils, sinuses, and they're finding out that there are a lot of these bacteria that are in our gut. So in the intestinal structures, there's a lot of research going on looking at the microbiome. We live with these organisms, and sometimes they can be deadly, but sometimes depending on what type of flora, and that's what it's sometimes referred to, this can also predict our health, our wellness, and the development of cancer. So in 2007, the National Institute of Health has started the Human Microbiome Project. And so again, this is sort of going back to Einstein's words. We don't know what we don't know about the microbiome, but we believe there's a real story there, which dictates how we digest nutrients, how we synthesize and digest vitamins in the nutrients, how our body breaks down drugs. So for instance, one dose of a medicine may not react the same in my body as it does in yours. And so that might have a lot to do with the enzymes and the flora that's present in our guts. And so again, this is a huge area of study. And any talk that you go to now about cancer, this topic will be discussed in some way or other. So then the next new thing that just sort of came out of the blue is the immune system. So there's a lot of research going on about how our immune system really works. So just that little picture there just depicts that there's immune tissue all over our bodies, our spleen, in our lymph nodes, it's in our thymus, whatever we have left of it as we grow up. Of course, in the GI tract, the immune system has been one of the most explosive areas of research in terms of understanding cancer and how our own immune system fights these cancers, and what happened to our immune system that allowed the cancer to develop in the first place, since it's sort of the watchdog over and surveys our bodies and what goes on constantly. So where is the breakdown in our immunity? We have different types of immunity. The ones that we're born with, we know that we get immunity from our moms and from breast milk. We get immunity that's adaptive after we've been exposed to certain things. That's one of the arguments with COVID right now. It's like, well, we will all finally be immune to this one way or the other. And then there's passive, again, that you get from your mom's breast milk and so forth. These are just kind of touching the surface. This is a huge area, and most of the research money and some of the folks on the call who work with the NIH and with the grants that are being awarded at this point, they can attest to the fact that a lot of the research that now presents itself to the NIH has something to do with the immune system. It's actually a pretty beautiful story. Everyone probably has heard of melanoma, malignant melanoma. It is a skin disease that kills most people, or did in the past. And I can remember going to meetings, and they would talk about every study, every drug, everything they ever used on melanoma. Well, it didn't work. So it was incredibly disheartening to hear that, because in the South, we see a lot of patients with melanoma, very young patients with melanoma, and it can be very devastating. But this is one of the areas where there was one of the biggest breakthroughs with the immune system, is that there are now drugs that are available that can put this disease in a state of sort of quiescence for a while, and can also put this tumor away for some people. And so this has been a very significant breakthrough. So you can just think of any tumor now. So all of the research, let's say, for instance, lung cancer, head and neck cancer, studies are being done with breast cancer and the immune system. It's like, how can you turn something went awry with the immune system so that these cancers develop? So how can we turn this immune system back on and give the patients drugs so that their immune system will work for them? And that's where a lot of investigation is now going on in all over the world now. So just to kind of wrap this up so that we can have more time to talk, you know that there are several common cancers: lung, breast, colorectal, prostate. So, and that's just sort of I don't know, there's just a very small minority of the cancers that we have to confront and deal with. But they're big ones and they're common, and there are ways that we can screen for them. There are some behavioral things that we can teach youngsters about, especially with lung cancer. There are screening techniques for lung cancer potentials, I'll say that. If you have a lengthy smoking history in the past, there are ways to screen for people who are at risk so that cancers are found at an earlier time using something they call a spiral CT scan. I'm sorry, guys, I'm at work and we'll just have to ignore that for a minute. The breast cancer, of course, with the mammograms and MRIs and ultrasound, and the colorectal is really moving up with, I think more and more people now are getting colonoscopies done when they should get them done. And so that's also important. And we can't forget about prostate cancer because it can be deadly in young African American men. For a certain population of men, they might have prostate cancer, but it's never a threat to their lives. They can live with the disease. But you have to be sure that you're one of those persons. So you have to get your PSA checked so that you can see, looking at the prognostic factors for prostate cancer, if you fall into the good group or if you fall into the aggressive group. And you really have to follow the recommendation of your physicians for that. So it's like, how do we develop these treatments for patients once you've been diagnosed with any form of cancer? So there are national guidelines, there are international guidelines that really speak to the comprehensive nature of cancer and how it should be managed. What is the proper way to stage the patient, biopsy the patient, treat the patient, what are the options? And you can find some of those guidelines again if you go to the NIH or really the NCI's website. You can see some of those common guidelines that are used basically around the world to dictate what type of treatment you should get. There are teams, and a lot of times patients come in and they don't know who is on their team. And if you remember the word analysis of oncology, so the doctors who take care of you, those professionals are oncologists. Surgeons usually lead that team. You have radiation oncologists, medical oncologists. You have advanced providers that are important in the care for patients. The people behind the scenes are the radiologists, the pathologists, your nutritionist, your social services, your supportive care team, because they are very important in trying to be sure that the person is well emotionally and they have the resources to be able to deal with and confront the current problem. So the next thing is that if you're diagnosed with cancer, you need to know what stage that cancer is in at the time of diagnosis. And your physician can tell you. There are, again, national protocols that really help to determine what stage you're in, because that dictates in a lot of circumstances what treatment you get. You want to know what your pathology report shows, because your neighbor's pathology for breast cancer is not going to be your pathology report. So you can sometimes share notes, but a lot of times you cannot, because there might be, let's say for breast cancer, for instance, there might be hormonal status or the lack of, or HER2 markers, or they look at something they call oncotypes now to decide who's going to get chemotherapy. So there are lots of things about the pathology you want to be aware of. And then the molecular marker world has exploded. That arena now investigates, again, getting back to the genome. Where are the mutations? Where did these mutations start? And so we've got a whole new world of molecular markers and prognostic markers. And you want to know if your tissues were analyzed for the proper markers. The hormone markers are, again, very important to investigate. So these are the kind of questions you want to have and be able to review with your care team when you're making decisions about yourself or about your family. And so just to wrap this up, research is really the key. And so it goes in stages. You have your preclinical stages of therapy design, and this is when you start either in some sort of very, very basic laboratory, looking at culture of cells and how they respond. Then you move all the way up to your animal studies, and then in humans, you have your phase 1, 2, and 3 trials. And again, I invite you to go to the NIH's website, clinicaltrials.gov, and you can basically put in your diagnosis or a family member's diagnosis, and you can see if there are studies in your area. I think I know it can be so mind-boggling when the diagnosis is rendered, then we sometimes forget. And even the physicians, they want to get, the cancer taken care of. We want to do the surgery. Let's go ahead and get things done and taken care of. But you also want to just take a breath and see if there are clinical trials that you might be eligible for. And so I want to acknowledge both organizations for this opportunity. The American Cancer Society, there are several medical journals. A lot of the images that you saw came from the Google images. And then the clinicaltrials.gov that I mentioned is a very important resource. So I'll stop there and see if there are questions.
Okay, thank you so much, Dr. Spencer, for that wonderful presentation. If you can release the screen back, we will look at some of the questions at this time. And we've got a lot of questions today. Thank you, guys. Let's go right here. And we'll start, I guess, with the first questions. And if I see something that's repetitive, I won't mention it. But we're going to try to address some of the questions. But also keep in mind that we will, if we can't get to all of them, we will try to send them to you, maybe some answers to some of this in an email. Let me see. The first one talks about, okay. With the expanded use of research over the past few years, would there be any emphasis on now on cancer in African American population? And the follow-up to that is, has the COVID crisis brought more attention to cancer in African Americans?
And that's my question, Dr. Spencer.
Okay, thank you so much. That is a great question. So there, again, it is not ideal, right? So there are pockets of research that are being done in the African American communities. Some that are specific to, let's say, just where I am, where there's a region we call the Black Belt. In the past, UAB has partnered with Morehouse, they partnered with Tuskegee, and with folks in the Black Belt area to see if you can get the information there, the testing there. There have been grants to do screenings for patients. And so there are small pockets there. We have a very active person at UAB, Dr. Mona Fuad and her team, and they do a lot of research in underserved populations. But to get to your question, of course, there needs to be more. And within the cooperative group structure, which there's several what I call clinical research groups that look very carefully at recruitment, because that's important. How can we recruit the correct populations? Gender, race, age, because you really need everything there to be present and represented so that you can see, okay, are the epigenetic factors different in this population? Are the genetic factors different? Why does this population not do as well? So to answer your question, the studies are there, they're not enough, and hopefully there will be more in the future.
The last part, Loretta, I apologize. I want to ask one more question with Dr. Spencer, is do you think there will be a redesign of clinical trials that would be more inclusive of these special populations in light of what's been uncovered in the COVID crisis?
I really do think so, because boy, so in some cities, right, in some cities it has been glaring that certain populations, African-American populations, underserved populations, they are having more devastating outcomes secondary to COVID. And so I think that is a rallying cry for all investigators, right, to say that we need more investigation in this population. And I think it's going to help. It's bad that when we get into a panic, right, that things come to light, but sometimes panics will help us do better.
Okay, very good. Okay, the next question says, due to COVID-19's extreme impact on the immune system, are you aware of conversations that it will also impact cancer incidence, etc.?
Right, so for part of that question, I don't think I know the answer to the end of that question, but I do know that for our population, we're testing everyone before they start, our cancer patients, because just by the nature of the disease, most of them have some sort of compromise in their immune system. That's why they have cancer. And then they're at risk for COVID and they get COVID. And so we want to be sure that we capture this for the current care of the patient and also for research. So we're hoping that there will be some great research questions that will come just from, we're treating these patients with chemotherapy, radiation, we've got these COVID tests on them. What is the outcome for those patients? And maybe that will get to the last part of that question. We don't know if they will be at higher risk for malignancy or not, but it might be that they don't respond as well. We don't have any indication for that right now. It seems like the COVID patients who have cancer, they do okay with their treatments. And it's too early, though. It's too early, right, to know if the 2-year survivals will be the same.
Yeah, okay. Okay, the next question is, will you say that taking probiotics is a good thing? If so, is there a certain dosage?
That's an excellent question, one of those epigenetic questions. We do think that probiotics are probably good. What I tell my patients, look for a reliable label, because let's say, for instance, a company that's been in the marketplace for a while, the Bayer company, the companies that makes milk of magnesia. Just, you know, look for a reputable company that's making the probiotic, and and it's a guess, you know, they will say that you should take 1 or 2 of these capsules a day, but it really does help with, I know some of the GI distress that some of my patients have when we put them on like Philips probiotics and those kind of things. So just look for a reputable company, and we think that they do help.
Okay. The next question, your thoughts on breast cancer not being caught despite doing annual exams?
Yes, so that is always disturbing when that happens. So these patients are doing everything they should. They are doing the exams, they're getting their mammograms done, and for some reason they will have just a normal mammogram, and then these aggressive subtypes show up. So they're working, as you might imagine, on, let's say, can we do a blood test, right? So that's almost like the Holy Grail. If you can find a blood test for breast cancer patients, and people are looking into that to see, we need something better than the mammogram and MRI in certain populations of patients. And hopefully the epidemiologists will help us discover who those are. We know some of those folks, the people who really have the triple negative breast cancer. We know that those tumors can misbehave in some people, but in other folks, I've seen the triple negative patients do fine. But just in general, it's a sort of a different subtype that needs special attention. So we're hoping for some sort of blood test, but we don't have it now. So you just have to be a guardian of your own health, to do your exams and to get your mammograms when they should be done. And again, if there's something unusual happening, if one person does not listen, find the next person who will.
Yeah. Thank you. And this will probably be our last question because we're running out of time. And it says the USPSTF recommends screening mammograms at the age of 50 for women. However, I've seen lots of African-American women diagnosed much earlier than that. Should AA, African-American women, request mammograms from their primary physicians before, if they're a younger age group?
Yes. And you know, a lot of those physicians will do it, right? Because they understand the risk. You will have a problem with your insurance company. That's kind of a lot of times where you will get a little bit of resistance. But we have a lot of patients that we still recommend that they get mammograms younger. You know, it used to be 35, right? And then when they did sort of the science of it, so to speak, and we don't know who all was represented in some of those studies, right? We don't know what the true representation was, that they have continued to move that from 35 to 45 and now to 50. And if you look at the studies, they will tell you diagnose cancers at a younger age, but they look at the cost.
Yeah.
The big studies came down to a cost analysis. And then there was a behavioral component to that. It's the anxiety. So they brought that in, the anxiety of doing all of these mammograms to find the few mammograms, even though you find more at younger ages. There's a cost, and then there's the emotional sort of toll that it takes on folks when you have to go through the mammography suite. So yes, I think we have to lobby the insurance companies, do more studies that have African American representation. Again, so African Americans have to participate in the studies so that we can make our case.
Okay, I think we're pretty much out of time, guys. Thank you so much. And I see that some of your questions refer to some of the other sessions that we have planned. So we want to probably earmark those for later. We actually had one on stress, and we did have another one on COVID-19 dealing with cancer patients. So these screenings, these presentations will be available to you, those that registered, so you can go back and probably check them out later. And if you have additional questions, feel free to send them to Tia Tumlin or to myself, Loretta Herring. And our information is in the flyer that was sent to you. We want to also give a great big thank you to Dr. Sharon Spencer, our presenter for the hour, and also to thank our sponsors. Amgen is one of our sponsors for the presentation. Also, we have sponsors that provide some of our gifts like Hello Cure, and Tia Tumlin has gifts, I'll have gifts. And so we just want to thank those people that made these presentations possible. And with that, I think that's it. Thank you so much.
Great seeing
Thank
you again,
you.
Dr. Spencer.
Good to
And
see
Loretta,
you.
you're fantastic.
Thank you, Sanford. And I see several people like Zach is on. Zach was one of our award winners for our Dr. Spencer Award last year. Thank you, guys.